I have no disclosures that are relevant to this presentation. So this morning I wanted to describe the burden of pneumonia in children, review the management of pneumonia based on recently published guidelines, define and characterize complicated pneumonia, and then review the management of empyema. So first, looking at the global burden of pediatric pneumonia. There are 156 million new episodes each year worldwide, 151 million in the under-resourced regions of the world. The top of this list is India with 43 million cases, followed by China with 21 million, and in the United States, about 2 million episodes of pneumonia per year. If we look at the global distribution of deaths among children under 5, this data from 2010, there were 6.9 million deaths, and of those, the majority were from pneumonia. You can see here, 19%. Look at the deaths of children by WHO region, that's the World Health Organization. You can see in every region, the pneumonia, which is shown here in green, pneumonia is the first or second most common cause of death in every region. And if we switch and just focus just on pneumonia, this data from 2012, pneumonia accounts for 17% of all under 5 deaths. That's about 3,000 children per day, for a total of about 1.1 million per year. And most of the children were less than 2 years of age. So where do these children die? About 265,000 die in the hospital, 99% of these deaths in under-resourced regions, and 81% of the deaths happen outside of hospitals. So efforts are needed to focus on early diagnosis and early intervention. And what are the risk factors for pneumonia? First is age. The youngest are the most vulnerable. Risk factors also include birth weight, nutritional status, overcrowding, environmental exposures including wood and dung burning stoves, secondhand smoke, and preceding upper respiratory tract infection. So this may at least partially explain why the numbers of cases of pneumonia are so high in under-resourced regions of the world. Again, looking at the global perspective on pneumonia mortality, it's the leading cause of death in children worldwide, with a fatality rate of about 20% in resource-poor countries, and this in contrast to the fatality rate for meningitis, which is closer to 50%. So in total, this is more than AIDS, malaria, and measles combined. Every 20 seconds, somewhere in the world, a child dies from pneumonia. And many of these deaths are preventable with vaccinations and appropriate treatment. So in the United States, we immunize children 2 months, 4 months, 6 months, and between 12 and 15 months with pneumococcal conjugate PCV13. If the same vaccine was available around the world, it could protect against more than 70% of disease-causing serotypes. Now, total, there are more than 90 serotypes of pneumococcal bacteria, but the majority don't cause significant disease. But the majority do not cause significant disease. So now, considering the diagnosis of pneumonia in children, again referring to the World Health Organization's criteria, they include cough and difficulty breathing, chest indrawing, and documented tachypnea at rest. And it's important when considering tachypnea to be aware that the threshold for determining that a child is tachypnic is based on their age. So for the youngest children, less than 2 months of age, that threshold is more than 60 breaths per minute. 2 to 12 months, it's more than 50 breaths per minute. And between the ages of 1 and 5, it's more than 40 breaths per minute. So this may be sufficient for diagnosis in places where bronchiolitis and asthma are less prevalent, particularly non-affluent countries where bacterial pneumonia is more prevalent. So now, using the WHO criteria for diagnosing pneumonia in children 2 months to 5 years, when considering cough and difficulty breathing, chest indrawing, and documented tachypnea at rest, this has very high sensitivity but low specificity. So what happens if you have fever to this WHO criteria for diagnosing pneumonia? there's substantially improved specificity with very little loss in sensitivity. So here we can see that using the fever, adding this goes from 62 to 70 to 57% in sensitivity, so very mild reduction, but the specificity increases from 16% to 50%. Now, what if we add signs and symptoms to the WHO criteria for diagnosing pneumonia? And the signs and symptoms including crackles and pleuritic pain. There's a high degree of specificity. The challenge here, though, is it's poorly reproducible, as there's little agreement between observations by different people. What about adding oxygen saturation? Does this matter? So if we look at oxygen saturations at 94% or below, the sensitivity is 26%, specificity increases up to 93%. And if you consider fever, tachypnea, and reduced oxygen saturation, the presence of at least two of these signs is associated with a high risk of pneumonia. But the absence of all three, I think just as importantly, tells you that pneumonia is very unlikely. Now, when considering the diagnosis of pneumonia, we've talked about cough, which is often productive, tachypnea, fever, oxygen saturation, auscultatory findings of crackles, chest pain, and respiratory distress, including grunting, retractions, and nasal flaring, sometimes seen in children with more severe disease. Now, when thinking about these clinical features, it may not be evident in every child who's diagnosed with pneumonia. They may have no acute illness. In one study, 5% had only fever. When considering the respiratory signs and symptoms, there can be none, and it can be just the child may just present with abdominal pain. And wheezing, although more common with viral, mycoplasma, or chlamydia infections, it does not exclude a bacterial infection. Now, what about adding a chest X-ray? Does this help make the diagnosis of pneumonia? So shown here is a child presents to the emergency room with fever and tachypnea. You can see this infiltrate the right upper lobe. Chest X-rays are found to be both sensitive and specific. Sensitivity as high as 75%, and the specificity, depending on the study, ranges between 42% and 100%. Now, the question is, does the X-ray help with the etiology? Well, when chest radiographs are subjected to blinded readings, they cannot differentiate between viral and bacterial disease. You can see scattered infiltrates, which make a viral infection more likely, or lobar infiltrates, or large pleural effusions, or parenchymal necrosis, which is more suggestive of a bacterial cause. But again, just looking at the X-rays, you can't differentiate between viral and bacterial causes. Now, I'd like to move on to discuss the clinical practice guidelines, which were published in 2011. They were developed to help decrease morbidity and mortality for community-acquired pneumonia in the United States. The definition of community-acquired pneumonia, it's the presence of signs and symptoms of pneumonia in a previously healthy child caused by an infection that has been acquired outside of the hospital. And again, looking at the numbers in the United States in terms of diagnoses, about 3 million outpatient visits for children in the United States. More of these visits are seen for the younger children, less than 2 years of age, versus the 3 to 6-year-olds. Hospitalizations, about 150,000 per year. And again, age-dependent, where the younger children are hospitalized more frequently than the older children. And finally, mortality, although the number is small, not insignificant at 525 deaths per year. So the guidelines were developed for primary care and subspecialty providers responsible for the management of otherwise healthy infants and children with community-acquired pneumonia, both in outpatient and inpatient settings. They were developed by the Pediatric Infectious Disease Society and the Infectious Disease Society of America, with experts from community pediatrics, public health, and pediatric subspecialties, including critical care medicine, emergency medicine, hospital medicine, infectious diseases, pulmonologists, and surgeons. They were published in 2011. about 52 pages with 92 recommendations. And I think very importantly, when they evaluated the literature to support these recommendations, they've included this in the guidelines, giving us the strength of the recommendation and the quality of evidence supporting those recommendations. And then I've added some red flags just for emphasis. So the topics in the guidelines include management decisions, diagnostic testing, anti-infective treatment, and management of the child not responding to treatment. So the first recommendation regarding pulse oximetry, the recommendations are it should be performed in all children with pneumonia and suspected hypoxemia. Remember that the presence of hypoxemia should help guide decisions regarding the site of care and further diagnostic testing. So if you have a child who presents to your clinic with a low oxygen saturation, you're going to have a low threshold for considering transport to a place where they can get more definitive care, perhaps the emergency room or directly to the hospital. This recommendation had moderate quality evidence. Complete blood cell count. So the recommendations from guidelines is that routine measurement is not necessary. This is a weak recommendation with low quality evidence. But a child who's got more severe disease must be interpreted in the context of the examination and other laboratory and imaging studies. Again, this is a weak recommendation with low quality evidence. What about acute phase reactants, like the erythrocyte sedimentation rate or C-reactive protein? So these are routinely not recommended. They can't be used as a sole determinant to distinguish between viral and bacterial causes of community-acquired pneumonia, but they may be helpful in those with severe disease to assess the response to therapy. Now, if you take the combination of white blood cell count with differential plus the C-reactive protein level, we find that when very abnormal, they're predictive of a bacterial disease, but they don't help distinguish between viral and bacterial pneumonia until the levels are very abnormal. What about blood cultures? Blood cultures are not routinely recommended for non-toxic, fully immunized children. They should be obtained in children who fail to demonstrate clinical improvement and in those whose progressive symptoms or clinical deterioration after initiation of antibiotic therapy. So they should be obtained in children who fail to demonstrate clinical improvement and in those who have progressive symptoms or clinical deterioration after initiation of antibiotic therapy. This is a strong recommendation with moderate quality evidence. What about testing for viral pathogens? So the test for rapid diagnosis of influenza virus and other respiratory viruses should be used, particularly if you're in the midst of a viral season. A positive influenza test may decrease both the need for additional diagnostic studies and antibiotic use while guiding appropriate use of antiviral agents. However, it's important to remember that the viral infection may precede or accompany a bacterial infection. What about mycoplasma? Important to remember that mycoplasma is certainly less common than other bacteria. It's identified in only 3 to 23% of children, primarily school age and adolescents. And what's different about the presentation is these children usually have slowly progressing symptoms, malaise, sore throat, low-grade fever, and the cough develops over 3 to 5 days. Chest x-rays. They're not necessary for patients who are well enough to be treated in the outpatient setting. This is after the evaluation in the office, the clinic, or even in the emergency department. But they should be obtained in patients with hypoxemia or significant respiratory distress or those who have failed initial antibiotic therapy. And I put the red flag here because it's very tempting to perform a chest x-ray in a child who comes to your office who you suspect pneumonia. But again, weighing the additional information you get from the chest x-ray, for those you can diagnose clinically, may not be necessary. Now, follow-up chest radiographs. Repeated chest radiographs are not routinely required in children who recover uneventfully. However, we do recommend them, or these are recommendations from the guidelines, follow-up x-ray in 4 to 6 weeks in patients who've got recurrent pneumonia involving the same lobe, lobar collapse, suspicion of an anatomic abnormality, chest mass or aspiration. Or I would include in this list patients with more severe disease. And important before moving on to therapy is to consider the age of the patient, because the organisms that cause the pneumonia vary based on age. Although you can see that strep is the most prevalent bacteria in many of the age groups. Here in the 1 to 12 month group, 1 to 5, and here in those children who are greater than 5 years of age. However, a definite pathogen is rarely found. This is as low as 2% in some reports. And again, important to remember that viral infection may precede or accompany a bacterial infection. Antimicrobial therapy. Again, another red flag, because the recommendations from the guidelines that these are not routinely required for preschool-age children, because viral pathogens are responsible for a great majority of the clinical disease. So in this situation with a viral illness, antibiotics are not helpful. There's a potential risk for adverse reactions to the antibiotic. And I think the more important, bigger question is about the facilitation, the development of antimicrobial resistance. So in being stewards for overuse of antibiotics, important to use them only when really indicated. So antimicrobial therapy, given that strep is the most common organism, the antimicrobial recommendation is to begin with amoxicillin. Should be used as first-line therapy for previously healthy, appropriately immunized infants and preschool children with mild to moderate pneumonia, suspected to be of bacterial origin. Here are the dosing recommendations. Amoxicillin starting at 90 per kilo per day in 2 doses, or 45 milligrams per kilo per day in 3 divided doses. And the alternatives include a second or third generation cephalosporin, levofloxacin, or linezolid. What about mycoplasma? As I mentioned previously, this is less common, and the presentation is a little bit different. And important to know that the testing for mycoplasma infection is important when making decisions about starting therapy. However, there are no currently available tests that are sensitive and specific in the relevant time frame. So it takes too long to get the results back to help it inform your decisions about therapy. And here I've listed the treatment for mycoplasma for the sicker children who are getting parenteral therapy. This is going to be azithromycin IV. For those with either step-down therapy or more mild infection, it's going to be, again, azithromycin, but you'll be taking it by mouth. What about influenza antiviral therapy? So in those with moderate to severe worsening pneumonia, when there's widespread local circulation of influenza virus, early treatment provides the maximal benefit. Treatment should not be delayed until confirmation of positive influenza tests. Negative rapid antigen tests, it's important to remember, do not conclusively exclude influenza disease because they're only 50 to 70% sensitive. And although the goal is to try to identify these patients early and treat them, treatment after 48 hours may still provide some clinical benefit. And the treatment, oseltamivir, this again is dosage is based on age, and I've included this in these slides. So based on the age of the child, you're going to be changing the dose, including now dosing recommendations for premature infants. Now what about the non-responder? So following the guidelines, the definition of a non-responder is someone who does not improve on therapy within 48 to 72 hours, or if there's significant worsening at any time after initiation of therapy. So for the child who's not responding, you want to reevaluate them, maybe bring them back to the office, consider whether you need further testing, maybe they need additional therapy or change in antibiotics, perhaps need admission to the hospital, and then you also have to consider the possible complications. So the possible complications are divided between the non-pulmonary complications and the pulmonary complications. At the top of the list of the non-pulmonary complications is sepsis. So for the child who looks acutely ill, perhaps looks septic, they're going to need rapid transfer to a place where they can get appropriate therapy. but I really wanted to focus on the pulmonary complications, specifically pleural effusions, and then empyema. So empyema is a pleural space infection. Its derivation is Greek, bion, meaning pus, and empyein, meaning pus producing. And pus is a thick, viscid fluid that appears to be purulent. Now, to get a sense of how many of these children with pneumonia actually develop empyema, 156 million new episodes of pneumonia each year around the world. 1% of these children will progress to have a parapneumonic effusion, but only 0.6% will progress to empyema. In the United States, there are about 3 million outpatient visits for the treatment of community-acquired pneumonia. Again, I mentioned there were about 150,000 hospitalizations each year, and of those, 1.5% will be hospitalized with community-acquired pneumonia and develop empyema. So it typically begins with a bacterial pneumonia. You develop a parapneumonic effusion, which is due to increased capillary permeability, which favors migration of inflammatory cells, specifically neutrophils, lymphocytes, and eosinophils, into the pleural space. And then once you have that infusion, it becomes an empyema once that effusion gets infected. It's more common in boys than in girls, and more common in younger children than in older children. It's more common in the winter and in the spring. High morbidity, and that often requires hospitalization, sometimes visits to the intensive care unit, and procedures, sometimes single, sometimes multiple procedures. But from a recent report, empyema in children, the final outcome is almost always excellent. The etiology of empyema, very similar to what we saw with pneumonia. Strep is at the top of the list, followed by staph. And increasingly, we're seeing MRSA, or methicillin-resistant staph, emerging as a pathogen. In the United States, rare to have Mycobacteria tuberculosis as the cause of empyema, but certainly something to consider with your international patients. And then the other organisms, a list including influenza type B. Now, when considering the serotypes that cause pneumonia, looking here specifically in North America, you can see that the serotypes that are most common, serotype 1, 3, and 19A, are all in the PCV13, which was released in 2010, but none of these were in the PCV7, which we started to use back in 2000. What's been very interesting about the story of empyema is that here, since the introduction of PCV7 back in 2000, the rates of empyema have been increasing. These are just two different age groups. This is the 2 to 4-year-olds. This is in the less than 2-year-olds. So increasing in both of these age groups with the highest rates in the youngest children. At the same time this is happening, this is the same graph that I showed you on the previous slide with the empyema-assisted hospitalization rates. At the same time here, pneumonia, seen with this line with the squares, the rates of pneumonia hospitalizations have actually been decreasing. And this is here on the x-axis, 1997, the most recent data point collected in 2006. So this has led to some really interesting questions. Why are we seeing an increase in empyema at the same time that we're seeing a decrease in the rates of pneumonia? So one suggestion is perhaps it was the introduction of the pneumococcal vaccination, specifically the PCV7. So the emergence of strains not included in the vaccine, perhaps that we've done something to suppress some strains but let others flourish. Supporting this, the rates are increasing in regions where the vaccine has been used, but not supporting this is the observation that the increase was noted before the vaccine was introduced. Other considerations have been climate change. There were, because of the gradual increase in the Earth's temperature, there's been a change in the microorganisms that are supported in different regions. And finally, bacterial resistance may be changing, and this may be in part due to antibiotic prescribing practices, which have been many infrequent. So maybe overuse of antibiotics have led to some increased resistance and allowed for the emergence of more different strains. And the cost of empyema, direct costs are approximately $20,000 per episode. Most of this is driven by the cost of hospitalization, prolonged hospitalizations with an average of about 6 days in the United States. This would also include the cost of an intensive care unit admission for some children, and surgical procedures, again, which may be single or maybe multiple. And then the indirect costs, which are always harder to estimate in terms of missed school while the child is in the hospital or at home recovering, and then the lost parental work, when they lost time when parents stay home to take care of their children. So now I'd like to review a case. This is a 4-year-old who presented with cough and fever. She had 1 week of cough and fever. Fever was tactile. 1-day history of trouble breathing with poor oral intake and decreased activity. Her respiratory rate in the office was 32. Her oxygen saturation, 97% in room air. And on examination, you hear coarse breath sounds, but no crackles and no wheezing. You're considering the diagnosis of pneumonia and obtain a chest x-ray. And here you can see that she's got bilateral infiltrates, some here in the right lower lobe, but much more involvement in the left lower lobe, perhaps the lingula. So bilateral infiltrates, much greater on the left than on the right. So following the guidelines, you treat her with amoxicillin, send her home from the office. But at night, she starts breathing more labored. Her breathing becomes more labored. She has more respiratory distress. You get the phone call at night and decide to refer her to the emergency room. So in the emergency department, she appeared quite ill, fatigued and in respiratory distress, with supraclavicular and intercostal retractions, nasal flaring, and intermittent grunting. In the emergency room, her temperature is 39.2 degrees centigrade. Her oxygen saturation in room air is 93%. Her heart rate was elevated at 183. She was tachypnic with a respiratory rate of 62. She had decreased breath sounds on the left, but no crackles were heard. Her white blood cell count is 24.7, and she has a viral panel sent. Rapid influenza A, B, and RSV were all negative. So you decide at that point to repeat her chest x-ray. So it's different now than the previous film. She does have some mediastinal shift, and you can see a pleural effusion. You may be able to see the outline of it here, extending all the way down. So then what do? Well, following the guidelines, done the laboratory studies, done the imaging, you may want to consider whether this is a child who you would need to perform a drainage procedure, and then finally make a decision about her treatment. And this is taken not only from the US guidelines, again published in 2011, but the American Thoracic Society guidelines published in 1962, the more recent British Thoracic Society guidelines in 2005, and the Thoracic Society of Australia and New Zealand guidelines, which were published in 2011. So first, white blood cell count. Well, this was performed. You already found that it was elevated. If you look at the differential, she's likely to have a neutrophil predominance, but it does not differentiate from bacterial or viral infections. This CRP was done in this child who appeared quite ill. It was elevated initially, but often will reflect improvement as it decreases. We recommend repeating it, and this is also, according to the guidelines, only if it's clinically indicated. And the blood cultures, again, it's frustrating because rarely is it positive, but in the case where it is, it really can help you guide therapy. So it's recommended, but most often negative. And probably this is because of the prior treatment with the antibiotics. So the viral panel. Again, this was considered because the viral infection may proceed or be a co-infection. Considered mycoplasma. Performed her platelet count, hemoglobin, and hematocrit. Because of the possible complication in this child who appears quite ill of hemolytic uremic syndrome, which has been associated with empyema, presenting with pallor, petechiae, and oliguria. You also may perform electrolytes with urea and creatinine. This is for the syndrome of inappropriate antidiuretic hormone, or SIADH, as well as the hemolytic uremic syndrome, which are known complications of empyema. Now the chest x-ray. We saw in this child the blunting of the chest wall, particularly on the left side. But here, just to show you, we're looking at for the blunting of the costophrenic angle and the concave surface, or you get this meniscus formed. Decubitus films can be helpful to show that there's free-flowing fluid, but they're really not necessary. What about CT? Well, it's not needed for initial management, but it can help you differentiate an effusion from parenchymal lesions, such as a mass, abscess, or necrotizing pneumonia. But the current recommendations are not using a CT, at least not early on in the course, and this is a strong recommendation with moderate quality evidence. What about ultrasound? Well, this is really the study of choice. It can identify pleural fluid. It can differentiate fluid from consolidation. It can detect fibrinous septations, and those are shown here in the figure. These are the fibrinous septations, which are clearly seen with the ultrasound. You can assess the size and the location, which can guide the chest tube. If you need to perform a drainage procedure, it can help you guide the placement of the tube. There's no ionizing radiation, and it's non-invasive, inexpensive, and easier to perform, as well as it can be done repeatedly. So now we're comparing these two studies, the 4-year-old boy with pneumonia and pleural effusion. In one study that compared children who had both of these procedures done, these were 19 children between the ages of 8 months and 17 years, all with pneumonia. When comparing these two studies, they found no benefit of CT over ultrasound. So what are the indications for removal of the fluid? When do you need to go ahead and either place a drain? So if there's the fluid that opacifies more than a quarter of the hemithorax, if the effusion is more than 10 millimeters on a lateral decubitus radiograph, or if the child is in a significant respiratory distress. Now what we know about empyema and drainage of the fluid, this goes back to Hippocrates in 400 BC, who wrote that when the empyema is treated either by cautery or incision, if pure and white pus flows from the wound, the patient will recover. But if mixed with blood, slimy and fetid, they die. So I think what he was describing is really the difference between a pleural effusion and an empyema. So when it becomes bloody, slimy, and fetid, likely it's been infected. And by definition, that's an empyema. So the pleural tap. Recommendations are now not to perform pleurocentesis in children. This is a strong recommendation with high quality evidence. The results are unlikely to change the need for more definitive drainage. It requires cooperation and in most situations sedation. It's uncomfortable, delays other interventions that will most likely be required for more definitive drainage, but this still remains controversial, with some experts advocating pleurocentesis prior to initiating therapy. Now the chest drain. Chest drainage hastens recovery and may help you identify the organism, thereby guide therapy. It drains the excess pleural fluid, which leads to more rapid resolution, can help re-expand the lungs, and restores normal pleural fluid circulation. Generally have two choices, either large bore catheter. You can see here this chest tube, or here the pigtail. And these are smaller, more flexible catheters. Get their name from their characteristic configuration. It looks like a pigtail. So deciding between these two, the larger tube or the smaller pigtail catheter, this remains controversial. The smaller ones are more comfortable, enabling children to mobilize sooner. They can get up and out of bed and even walk around with these smaller tubes in place. The larger tubes are less comfortable, typically more painful and a little bit more difficult in terms of being able to get up and out of bed while the chest tube is still in place, and it's not clear there's a big advantage of one over the other. With either of these approaches, you're going to continue until the flow of pleural fluid is decreased less than 10 to 15 mLs in a 24-hour period. What studies should be done on the pleural fluid? So once it's drained, either by pleurocentesis or once the chest tube is placed, initially the white blood cell count is raised initially. It will return to normal once the pleural space and lung parenchyma are sterilized. Initially, there'll be a neutrophil predominance, and lymphocytes should raise suspicion of malignancy or tuberculosis. You want to perform cytology, microscopic studies, as well as culture, including for Mycobacterium tuberculosis, and PCR for bacterial ribosomal identification where it's available. What about pleural fluid studies? There's currently no role for pleural biochemical markers in children. This is a weak recommendation with low quality evidence. The suggested findings, glucose levels that are low, below 60 milligrams per deciliter, pH, which is low, below 7.2, and pleural fluid LDH, which is greater than 1,000 international units per ml, or more than 3 times the upper limit of normal for serum. Now, what if you combine the chest drain with a fibrinolytic? It shortens the hospitalization versus chest tube alone with an overall success rate of 80 to 90%. And it may be superior to stiff drain. It may be superior to using the stiff drain and comparable to thoracotomy. It's the agent of choice, urokinase. The first dose is placed in the chest tube. Again, the dose is based on age. You're going to leave it in it for about 4 hours. Then place the chest tube to continuous suction. And then you're going to repeat the dose of urokinase every 12 hours for 3 days. And finally, if you're not successful with this approach, the next level of intervention would be video-assisted thoracoscopic surgery. It's useful when the chest drain and fibrinolytic is unsuccessful, but there's no clear advantage in terms of length of stay, days of oxygen requirement, days until children are afebrile, or their need for pain management. And it does increase the cost because of the surgical procedure. So in a study comparing the VATS versus chest tube drainage with fibrinolysis, the outcomes, including length of stay, were very similar. Chest tube, with or without fibrinolysis, were associated with a higher frequency of additional drainage procedures compared with VATS. And if outcomes are the same, the risks and benefits of the invasive procedure needs to be studied carefully. The treatment, again, you're going to consider the most likely organisms, strep being at the top of this list. Don't want to forget about staph and the possibility of MRSA. Typically, the recommendation would be to begin with ampicillin or penicillin G in regions with low penicillin resistance. Alternatives would include ceftriaxone. And then finally, if you're considering staph, particularly MRSA, you'd start vancomycin. Supportive therapy. Want to continue supplemental oxygen if the saturations are less than 93%, fluid replacement and antipyretics. Early mobilization and the encouragement of deep breathing and coughing will help mobilize the fluid. There's really no role that's been shown to be effective for, there's really been no role established for chest physiotherapy, and adequate analgesia to allow for pain-free respiration, and again, importantly, to allow for mobilization. And the outcomes from empyema. In a single center prospective observational study conducted at the Hospital for Sick Children in Toronto, 55 patients, mean age of 3.4 years, were recruited over 2 years between October 2008 and October 2010, and they were followed longitudinally for 1 year. The outcomes of empyema, 1 month after the hospital discharge, more than 25% of the patients had fever, continued to have fever and cough, some abnormal breath sounds. They're old enough to perform spirometry. You could document restrictive or obstructive lung disease. And they had chest X-ray abnormalities. As many as 27% had pleural effusions, and 4% had nematoceles. However, at 12 months, the abnormality seen on chest chest x-rays had mostly resolved. Only 2 had small pleural effusions and 1 had some pleural thickening. Spirometry in those old enough to do the study, 6% had mild obstructive lung disease. And important to recognize, at least in this study, that no patients were treated with VATS. And here, again, this is the child's x-ray I showed you earlier. Started with pneumonia seen in the office and referred to the emergency room when she became ill overnight, more severely ill overnight. Here's her x-ray 3 months after discharge. Almost complete resolution of the pleural fluid that was seen here. Now you can clearly see the left heart border, improvement even in the right lower lobe. So in conclusion, when evaluating a child with fever, tachypnea, and reduced oxygen saturation, remember that the presence of at least 2 of these signs is associated with a high risk of pneumonia. And I think as importantly, the absence of all 3 makes pneumonia very unlikely. Thinking about the chest radiographs, initially may not be necessary after evaluation for patients who are well enough to be treated in the outpatient setting. So you can rely on your clinical judgment without the need for a radiograph. But it should be obtained in patients with hypoxemia or significant respiratory distress and in those who failed initial antibiotic therapy. Antibiotics, optional for preschool-age children because viral pathogens are most frequent. For those who believe have bacterial pneumonia, amoxicillin is the first-line therapy. But I think an important message here is that it's important to reevaluate these children to see how they're responding in 48 to 72 hours to see if they need additional testing or additional therapy. Regarding empyema, it's rare, but the rates have been increasing. We're going to consider the diagnosis in children with pneumonia who failed to respond in 48 to 72 hours of antibiotic therapy. Morbidity is high, but fortunately, at least in the studies that have been published to date, mortality remains very low, and overall the outcomes are excellent for the majority of children.